Ladies and gentlemen, dear colleagues, dear Klockner and Botus friends, my name is Oliver Bielenstein. I'm one of the founders of Botus Biomaterials. Welcome to all of you who are online and present today for this wonderful clinic and scientific education event. Welcome to the bone and tissue community, who always strives for improvement and better results for their patients. Thanks a lot to the whole Klockner and Botus team who made this outstanding event happen. You have compiled a fantastic program with great lecturers and teachers who will make sure that we are all learning and take home valuable experiences which you can apply tomorrow in your clinics. And especially a big thank you to our partner Klockner. We built an incredibly strong partnership 15 years ago, which helped also us, Botus, to become one of the world's leading specialists in dental bone and tissue regeneration. And we stay strong together for many, many years to come. As the COVID pandemic is getting to an end, we hope to see all of you around next year in presence and look forward to celebrate this come together with a big party. But this year we still experience online learning. Have fun and exciting lectures. I hand over to my colleague, Benno Buchbinder, our Managing Director, to introduce one of our latest innovations. I can promise you something revolutionary. Have a lot of fun and enjoy this day. Bye.
Thank you, Oliver, for handing over. Also from my side, welcome to the Bone and Tissue Days. For me, it is always fascinating to see how consistently and professionally Klockner is arranging not only, but especially this Congress focused on all regeneration. Over the last years, we have seen many different products hitting the market, but the evolution has been less in the bone substitutes itself, but rather in their combination with different biological factors. This biofunctionalization can be done different ways: blood concentrates, autogenous bone, BMPs, but lately hyaluronic acid is increasingly in the focus of interest. All of the above-mentioned options are not available ready to use, but require either harvesting and preparation time or acquisition of rather expensive agents, which drove us to develop something simple and ready to use. So we combined Cerabone, one of the most widely used bovine materials, with recombinant hyaluronic acid. The result is the new Cerabone Plus. We have done an extensive limited market release phase over the last year with more than 250 clinicians involved all over Europe. Through an outstanding initiative from Klockner, more than 50 of those clinicians participated from Spain and Portugal, thus accounting for the strongest contribution of all participating countries. Thanks a lot for everybody involved. I appreciate every single feedback from you. Our aim to facilitate the clinical use of particulate materials was backed up by more than 85% of clinicians, which reported improved handling characteristics of Cerabone Plus compared to conventional methods. When looking at the known beneficial effects of hyaluronic acid, it is not surprising that the initial healing was rated to be excellent. The distribution of Cerabone Plus through selected partners has just started, with Klockner being one of the first companies to be able to offer it worldwide. But enough for now, let's get the conference started.
in some areas we have medium level closeness to the floor of the sinus. On the other place, severe atrophy and pneumatization of the sinus. So the same was performed. Implants were placed immediately with lateral sinus opening and elevation, and some augmentation procedures around the area where the tooth was extracted. 10 years later, this is immediately post-op, and 10 years later, one can see the stable situation using xenograft material, PRP, and covered with PPP. So if we look today on this situation, if I would ask what kind of treatment plan you have to such a condition. So we see here the three teeth, the second premolar and the two molars, the first and second left maxillary molars, and you can see a reaction of the Schneiderian membrane here, a small polyp. And we know today that this situation, when we have a polyp in the sinus or the Schneiderian membrane reaction, it's due to the infection of the teeth inferior to the maxillary sinus. So what would you do? In the past, we used to extract and wait. And what happened if we do extraction and wait? Let's see. And here you see the amount of infection and the teeth that need to be extracted and the reaction of the Schneiderian membrane. So of course, this is a different case, just to show you what happened if you decide to extract and wait. What happened is we get a shrinkage of the tissues, both the soft tissue, and of course we lose a lot of space due to the granulation tissue that were extracted and were not filled with any material. So this should be prevented. And actually the importance, and now we talk many times about socket preservation, which I don't like the name socket preservation, but ridge preservation. And if you see here, this is what we do today. Extraction, and there's the same patient, of course, extraction of the three rotten teeth, curettage of the infected tissue. This is the granulation tissue. Very thorough cleaning. With water peroxidized and saline, and then filling the defect with xenograft material, saturated in PRF in this case, covered with PRF, and sometimes I use a collagen membrane as well to cover the defect. And now pay attention what I do more, and we'll see it along the lecture. I use the buccal fat as a pedicle graft to cover the augmented area. And this is immediately after the operation. So the difference is that we don't get shrinkage of the tissues. And the most important, it is not only the bone, but also the soft tissue that overlie the defect. And now we know another fact, that the minute we take the infection out, we extract the teeth and we curettage the granulation tissue, the reaction of the sinus will be quite immediately later. So it will be a healthy sinus because the reaction was due to the infection, the dental infection. It's not a sick sinus. Let's take another case. If you look here and take a closer look, we can see here a problem. And if we look at the slice, at the panoramic slice from the CT, one can see two important things. The infection got to the floor of the sinus, but this time, sinus is really filled with polyps or pus. So we have a sick sinus. It's not drained anymore, and we need to treat it. So in such cases, it's not enough just to extract the implant, the ill implant or the failed implant, but we have to treat the sinus. But we have a problem, since if you look at the slices, we can see here, of course, you can see the right sinus and the left sinus, which is all filled with liquids, with pus probably. And here you see a defect in the floor of the sinus. So probably when we extract the implant, we might get a communication between the sinus and the oral cavity. So we want to prevent this communication. So for this, we gather together in the operating room, and it's a teamwork. So Dr. Yakirevich in this case is a ENT, and we work together at the operating room. So he starts with a FES, functional endoscopic sinus surgery, and you can see for that patient the amount of infection and pus that comes out from the sinus, from the left sinus, ill sinus, through the opening during the FES. And you can see here the pus, a lot of pus. So he cleaned it, washed the sinus, of course, drainage it, and then I go through the oral and clean, extract, of course, one implant. I decide to leave the two others. And now you see the buccal fat pad to prevent any communication between the oral cavity and the sinus. And I do use the xenograft material saturated this time in PRP, covered with PPP and with fat, buccal fat. So I prevent here the oral antral communication, as well as I do preservation of the crest. And here, if you look at this picture, this is a pedicle graft of the fat, the same case. And you can see here the vascular, here, the vascularity. So it's a pedicle graft, and the best thing, it's do three things. First, it gives volume, vascularity, of course, and this protect the entire augmented area. Where this buccal fat pedicle flap comes from. So if we look at this illustration, we can see here the masseter muscle, and behind it lies the buccal pad of fat, which is part of the fat. We have the temporal extension, the body, the buccal extension, and the pterygoid extension. What I take is a piece from the buccal extension, but it's a pedicle graft. I do not disconnect it. That's why it's a vascularized graft, pedicle graft, which gives vascularity to the entire graft. So this is a pre-op situation, and you can see here the amount of loss of bone, the neighboring sinus and the loss of sinus floor, and here immediately after operation. If you look at the literature about the efficacy of alveolar ridge preservation after maxillary molar extraction in reducing crestal bone resorption and sinus pneumatization. This is a multi-center prospective case control study. And another paper from early this year in April, effect of ridge preservation at the molar extraction site with severe periodontitis in the Schneiderian and on the Schneiderian membrane thickness changes, which is a pilot study. And the conclusion, sorry, alveolar ridge preservation performed after maxillary molar extraction may reduce the entity of sinus pneumatization and alveolar bone resorption compared to unassisted socket healing, which is very important. Moreover, this technique could decrease the necessity of advanced regenerative procedures prior to dental implant placement in posterior maxilla. The second paper that were published this year, the conclusion was, following extraction of molar with severe periodontitis, a reduction in swelling of the Schneiderian membrane has been observed, regardless of the addition of, they used demineralized bone socket graft. However, mucosal thickness stay frequently the same. Nevertheless, if we look back on this sentence and this conclusion, we might reduce the need of more augmented procedure if we use preservation, if we do preservation. So let's take this case and let's think what would be the treatment option for that case. So these two molar left maxillary teeth need to be extracted. And here we can see the part of the panoramic view. If I line here the floor of the sinus, and I line here the loss of bone, the amount of bone that were lost. And the first thing I did while extracting is preserving the area, bone preservation via augmentation with xenograft material saturated in PRP, covered with PPP, which is a platelets poor plasma. This is 5 months later or 4 months later, the panoramic and CT view of the same patients. So what we see here, this is very interesting, and the slice from the area of the extraction and augmentation. What really was the earning and the amount of bone that we earned through this augmentation procedure at time of extraction? So we can see here the second premolar, the left premolar, which will be like an internal standard for us. And this is the floor of the maxillary sinus and the line where the resorption was to begin with due to the infection of the molar teeth. And this is the amount of bone that we managed to gain through this procedure. So what are the treatment options now for such a condition? So we have option 1, augmentation procedure. We can do sinus augmentation procedure, and also we can do vertical augmentation procedure via only bone graft, for instance. The second, and to use a long and wide diameter implant. So this is one option. The second option might be use a short implants. This would be the illustration of using the bone that already exists after the first procedure at time of extraction, augmentation and extraction, bone preservation. So if we compare option 1 and option 2, what we would like to prefer today? So if you look at the papers published about the short implants, this was published 2020 and this is 2021. Short implants less than 8 millimeters versus longer implant with lateral sinus floor augmentation posterior atrophic maxilla. This is a meta-analysis. And the second paper is short implants less than 6 millimeters as an alternative treatment option to maxillary sinus lift. And what were their conclusions? Prosthetic rehabilitation with short implants less than 8 millimeters in the posterior maxilla is a reliable treatment option as an alternative to lateral wall sinus floor augmentation. Short implants reported high survival rate over short to medium follow-up in posterior maxilla. And this is the most important, but the long-term success is as yet not demonstrated. And this simple sentence is like a key for me to decide which treatment plan I desire for that patient. So I have decided to perform the first option, the augmentation via sinus operation through the lateral wall, and then augmentation, vertical augmentation with autologous bone block graft, harvested the bone to half and use it for vertical as well as horizontal augmentation on a base of a xenograft material as a scaffold saturated in PRP. I cover it all with PPP and again with a buccal flap from a pedicle graft from fat. So this is a time of operation before the buccal flap pad, and this is the flap, and immediately after the operation. One can see the floor, the amount of bone in the maxillary sinus, the onlay bone graft for vertical augmentation, and the previous augmentation performed at time of extraction. Let's see 5 months later, just prior to implant placement, and we'll examine the slices from the area of augmentation. And it's very clear how much bone we gain through these two procedures. The first at time of extraction, and the second as augmentation procedure. Here is the bone to begin with, the previous bone, the available bone before the extraction, and the rest is augmented material. So this is a time of implant placement. The fixation screw are taken away and implants are placed, 2 long and wide diameter implants. The level of the implants coincides with the level of the bone, and this is one benefit for the using of vertical augmentation. Otherwise, if we didn't do the first augmentation, the level of the bone was very high and superior to the level of the bone of the neighboring teeth, which leaves a huge amount of discrepancy comparing to the amount of bone that we have now. So this is the actual, what we managed to do in this case. And if I'd copy and paste the illustration that I did prior to the operation, one can see that this can be done. This is the plan and this is the actual. The actual and the plan. So for this case, first of all, you can see here the amount of bone we manage. It's not only bone, it's soft tissue. And the soft tissue, we have to consider this is very important to gain soft tissue in this area. So we have a better solution only after the bone preservation, and then we can add and we decide, depends upon the situation, whether we do another augmentation procedure, a time of implant placement simultaneously, or as a separate procedure. So if we look here at the pre-op, and this is 8 years later, at 2020, this is a stable situation. So today, I still prefer the long implant and the augmentation procedure, since we don't have yet a long-term result in the posterior maxilla when we have severe atrophy due to the loss of teeth or ill or failed implant with short implants. But we have promising result as I showed in the literature with short implant. And this is the clinical view 8 years later. Let's examine another case. If we look here, I would like to compare the right side and the left side. So what's the difference between the right and the left side? Look here at the right side. We already have area after extraction for many years and loss of bone, both vertically and pneumatization, severe pneumatization of the right maxillary sinus. On the left side, we need to extract a tooth, and we still didn't lose the area and the amount and the volume of the bone here. If we look at the CT panoramic view, let's compare the right and left. Here we have a healthy, clear sinus compared to a polyp due to the dental infection. So it's a reaction to the dental infection. In this case, when we know that the drainage is perfect and the only problem comes from the infection from the tooth, we don't need to collaborate or to do FAS here. The minute we extract the tooth, the infected tooth, the Schneiderian membrane will heal, even if we do augmentation procedure at the time of the extraction. So the difference here that here we cannot do augmentation procedure immediately, and here we can do and preserve some bone at time of the extraction. If we look at the CT scan of the right side, one can see the severity of pneumatization at the area of the missing molar. On the other hand, on the left side, we still have some bone, although we have an infection, but we have a very narrow floor, but still exists, and a barrier from the sinus cavity here and here. You can see still a very slim bone separating the floor of the sinus from the oral cavity. If you look at the patient, there is another problem that we have to consider. We have a wide buccal corridor here due to the loss of tissues, both bone and soft tissue. So this aesthetic problem need also to be taken under consideration. And you see here the lack of tissues, both vertical dimension and horizontal dimension. That's why we get such a wide corridor on the right side compared to the corridor on the left side. So this is also very important. Not only placing implant, so if we can put here short implants, what we can't because we don't have any bone, but if we could, we will not be correcting the aesthetics of her smile, as can be seen here. This is the intraoral view of the right side, and you can see here the discrepancy between the upper and the lower jaw, the intermaxillary distance compared to the left side. So the first thing for the right side was to augment both via sinus augmentation procedure through lateral wall procedure, using xenograft material saturated in PRP, and then harvesting bone from the ramus, from the lateral ramus, for vertical and horizontal augmentation. This is a procedure I teach here, and we do it for many years. This is a lateral wall placed in place. On top of it, on a scaffold of saturated xenograft material, I place the horizontal part, and this is the PPP harvested from the patient's own blood while preparing the PRP. And this is a buccal fat pad, as I always use at the posterior maxilla augmentation procedures. As I said, it gives volume and vascularity and protect the entire augmented area. On the other side, extraction and sinus elevation procedure. So here is the right side, just prior to the augmentation. And please pay attention to this line in between the two blocks, and we'll see it after a while at time of implant placement, and we see the incorporation of the bone. And this is the PPP and the buccal fat pedicle graft. So this is 5 months later, preparing for implant placement. So on the right side, I did augmentation procedure, both vertical with onlay bone graft, both vertically and horizontally, and sinus augmentation procedure. On the left side, I did only preservation with augmentation at the socket after extraction, the molar, the infected molar, with sinus elevation procedure. So let's examine the slices of the right and left sinus. So this is the post-op 5 months after augmentation procedure of the right side. Let's compare it to the pre-op. So this is 2 slices, pre-op and post-op. So this is the pre-op available bone that we had at the right side. And I tried to manage to sign it here with the red line. And this is the amount of bone we gained through one procedure. So this is a huge difference. And I do recommend in such cases yet to do augmentation both horizontally and vertically. On the other side, you can see the post-op 5 months after augmentation, sinus augmentation procedure, and bone preservation. And if we take a closer look on the pre-op, which we had a very little amount of bone and a reaction of the Schneiderian membrane, now we can see a healthy sinus, completely healthy sinus, and here the bone after the elevation procedure and the amount of bone we gained through the augmentation, bone preservation after extraction, the first left maxillary molar. This is the post-op on the right side, correcting the vertical and horizontal proportion and decreasing the amount of corridor on the right side. On the left side, the difference is less mentioned. Now I do the implant placement. Pay attention on this flap, and I'll show it later on. Screw are taken out. Implants are placed, 3 implants to replace the premolar and the 2 molars. And then I use again the buccal fat. And now I use a roll-up technique, modified roll-up technique, palatal roll-up technique to add volume to the buccal flap. This is connective tissue grafting actually, but it's a roll-up. So let's see. This is immediately after. Remember this line in between the block, and you can see here that there is no discrepancy and the healing is very good. This is the implant. Look here at the vascularity, the new vessels in the implanted bone, in the grafted bone. And we got a correction both vertically and horizontally. Let's look at the flap. Here we have partial thickness incision, and this is a full thickness incision deep inside the palate. So I can modify palatal roll technique, means that I roll it inside from the palatal side to the buccal side. So I roll it in, as can be seen in this illustration. This is incision A, a partial thickness incision. Let's go back to see it here. And this is the second incision, incision B, a full thickness incision deep into the palate, as can be seen here. And then I roll it into the buccal side under the flap to get more volume. This is already 6 months later, a time of uncovering the implants. Of course, on the left side, I placed 2 implants with the same roll technique at the roll-up technique of the palatal tissue. Time of uncovering. This is a very small operation. And you can see here the amount of tissue on the buccal aspect. And this is already after rehabilitation. Of course, I work with the team and I do only the surgery. And this time, my friend Hannah Yagil was doing the prosthodontist. So all the time I cooperate with prosthodontists. So let's see the pre-op. 2017, the right side and the left side, and 2020, 3-year post-op, you can see the right side, a stable bone, and you can still see here the plate of bone harvested from the ramus, and here I do bone preservation. You can still see here the bone preserved at time of extraction, the sinus elevation, and the 2 implants. I would like to recommend reading Minimally Invasive Management of Implant-Supported Rehabilitation in the Posterior Maxilla, Part 2. You can read, of course, Part 1 as well. Surgical Techniques and Decision Tree, written by this wonderful group led by Myron Navis. Thank you very much.
Dr. Deborah Schwartz-Arad, for your presentation. I'd like to pose you some questions. The first one, you showed us a case where you extracted the tooth and you preserved the bone at the beginning. In case you extract an implant communication with the sinus, would it be possible to place an implant there as a second procedure if needed?
This is a very problematic case, which I've decided to leave the 2 implants and to follow them, because I'm not so sure that there is a possibility to place another implant in such a severity of loss of bone due to infection around implant. Nevertheless, due to the fact that we have done this 2 procedure together, the cleaning, the clearage, and the drainage of the sinus through face, and the augmentation procedure, the bone preservation, one might think that it will be possible, but it will be, of course, it needs the necessity of probably more augmentation procedure at time of implant placement, or as I showed later on with another case, to do augmentation procedure again as a separate procedure and then implant placement.
Well, thank you for your answer. Another one would be like, what would you prefer? What would be the preferred time for implant placement after preservation procedure, when we extract and put xenograft material, since we know that xenografts do not reserve and it stays there forever? How come we can place an implant after 5 months? Is it too soon? Is it too late?
The same as we do in sinus augmentation procedure, as we simultaneously place the implant sometimes together with the implantation simultaneously with the sinus elevation procedure, where we use xenograft material. The same is performed here. I do the implantation. When I use a xenograft material, I never use it by itself. I always combine it and saturated it with either PRF or PRP, sometimes even bone marrow. If it's a very severe case, I use the bone marrow concentrated. So you need to use with the filler blood from the on patients, and this will enable to place implant immediately at time of after short time, let's say 5 to 6 months after the first procedure.
Well, thank you again. And the last question would be, when would you prefer to place short implants, and when do you prefer to make augmentation procedure with longer implants after extraction and augmentation procedure? This is more a biomechanical problem than some balance between mobility for bone augmentation and the survival of short implants. And at what level do you decide to use short or long implants? So this would be my last question. Thank you in advance.
So as seen in the literature, we are talking short implants might be 6 to 8 implants, which I think less than 6 is very, very short implants for the posterior maxillary area. So I use 8 as a most short implant that I use in the posterior maxillary area. And nevertheless, what I really think is important is the two important things: not only the amount of bone that we still have, the available bone, but also the discrepancy and the distance that we have both horizontally and vertically. So it's not only how many millimeters we have yet, but how much tissue is missing. We always count what we have, but we have to count what we miss as well. If we have enough bone, let's say 10 millimeter or 8 millimeters, and the discrepancy both vertical and horizontal is not that much, I would do short implants, I think, today, where in the past I would do a sinus elevation procedure. But if I do have a big corridor, buccal corridor, and missing tissue, both vertically and horizontally, I still prefer, and I think the better solution still today for long-term success and predictability is to do augmentation procedure, both via sinus augmentation procedure and horizontal and vertical augmentation procedure with block grafting.
Okay, hi everyone. Thank you very much to the organization for the invitation. It is for me a great pleasure to be here at the Bone and Tissue Day, which once again amazes with the quality of the speakers it manages to bring together at this event. Well-known national, international figures that I take the opportunity to greet. To the colleagues who are listening to me, thank you very much for your presence. Unfortunately, still in a virtual format, the pandemic still demands it. Today, I was asked to address the bone split technique, that is the use of cortical bone plates in the context of bone regeneration. So we'll have a few Q&A at the end, and I hope you like it. My name is Pedro Moura. I do surgery in periodontology, and in recent years, I have dedicated myself to foramen dental education, which is a training center of which I am the pedagogical coordinator. In this center, since 2013, we have been developing the concept of long-term clinical residencies in various areas of dentistry. These are long-term university master's degree. These are training programs of 1.5 days per week in which our students are immersed in clinical environment where they plan and perform clinical procedures supervised by more experienced clinicians. These are the people that help me at my residency daily. These are my students for 2018, 2019, last years, and these are my students this year. Nowadays, the time that I have left to do my own clinical work is virtually non-existent. This project takes up all of my time, and that is the reason that I'm showing you these pictures. The cases you are about to see are a joint effort between myself, my team, and our students. Today's presentation is divided into 3 sections. We will firstly be talking about decisions, so we'll discuss some of the important things to take into account when opting for this specific technique. Next, we will be discussing the split bone technique, and we'll finish by looking into variations of this approach. So this will be a straight to the point, simple presentation with lots of everyday clinical cases. I'd like to show you a decision tree. I'd like to start off by showing you a simple decision tree, horizontal decision tree, that illustrates my thinking process when we perform regenerative procedures. And this should be a simple thing. We do this daily, but it's really not. Even routine daily decisions such as what to do based on the buccal bone availability can be very unclear, particularly if you try to pass them on to others. I'll tell you how I see it. Flawed as it surely this attempt is, I'll walk you through this horizontal graft decision tree. If after my prosthetically guided implant is placed, all I am left with, I am left with more than 1 millimeter, well, then I do nothing, obviously. This is a study from Spray that measured changes in vertical dimension of facial bone between implant insertion and uncovering, and compared these changes to facial bone thickness for more than 3,000 implants. As the bone thickness would approach 1.8 to 2 millimeters, bone loss would decrease significantly. But if 0 to 1 millimeters is all I have, then I go for a narrower implant. This makes sense nowadays, 3.5 or even less. With 2 fractures per 1,000 implants, this is an appealing solution that increases the treatment spectrum and reduces or even eliminates completely the need for grafting. However, there are some biomechanical risks, such as peak stress interface between bone and implant, that some authors would relate to the possibility of peri-implant pressal resorption. And also, of course, they can break because of excessive load, so I'm not using them on molar side. And despite that, they can be an excellent solution for the anterior region, as their success rate is over 95%. And whenever we have our implant thread showing, now we go for GBR. This is widely documented in the literature. The materials are easily available. The amount available poses no problem. And the technique for horizontal GBR is fairly simple. Most of my implant is inside, in this situation, most of my implant is inside the alveolar bone, meaning that osseointegration is not compromised and initial stability is easy to obtain. So whenever it's possible, we like to add autogenous bone, whether mixing it with the biomaterial or layering it. And if we go for the last option, we place the autologous against the implant and a biomaterial graft on top. This is the sandwich technique proposed by the Wang group, Misha, Neva. Here's an example, a simple example of the concept. Tooth number 14 is missing. And we start by enlarging this crest by using an expander kit. At this phase, we're just trying to move the available bone around. This is a 3.3 implant. One can see that even expanding the crest and using a narrow implant, we are still left with a very thin bone layer on top of the implant. We can notice some exostosis present in the posterior area. And we use the bone scraper to collect bone from that area, from those exostoses. We used a couple of tacks to secure our membrane. This eliminates any chance of movement and allows me to place some tension onto the biomaterial, ensuring that the biomaterial too cannot move. This is a PTFE membrane, but in a case like this, we could just as easily use a collagen membrane. This is a very favorable, very simple case. The bone peaks are present and the material is easy to contain. So we layer these bone scraps first against the implant surface. And on top of this, we will place some xenograft to add volume and have a resorption resistant biomaterial protecting the site. As you can see, we will secure this membrane by using a few tacks, and we will also anchor it to the implant closing screw. So here we have our result after 8 months, okay? So we have become, as a community, we have become increasingly aware of the importance of soft tissue covering the available bone, particularly when we find that many of your implants, despite being successful treatments and serving their purpose in mouth for many years, under a CBCT scan and under a routine CBCT scan, and anyone that has a CBCT in their office knows that, those implants tend not to have much bone covering the threads at all. So whenever we have, it is important now to think of soft tissue more than before. Zucchelli is the spokesman for this current of thought. What we want really is a tissue around the implant that is thick enough to resist the bacterial insult without being completely inflamed, and inflammation that occupies the entire tissue. This will translate clinically into a recession, which is the event that triggers peri-implant complications. Now, when the available bone does not allow for a stable implant to be placed, then, as I see it, defect anatomy is crucial to the decision process. There are fundamentally different anatomical aspects in these three defects. If medullary bone is present in a no concavity defect, let's call it an A-type defect, and I can place my implant 1 to 2 millimeters subcrestal to make up for vestibular bone loss, then bone splitting can be considered. Of course, GDR, PTFE with titanium or collagen with tacks and tenpole and Curris plate technique can also be performed, but time and morbidity should be considered. So whenever we have this anatomy, here we may go for a bone split. But according to the literature, this is Bassetti 2014, we need to make sure that we have a minimal horizontal bone width of 2 millimeters, a minimal vertical bone height of 10 millimeters, no concavity in alveolar bone profile, so, and the horizontal osteotomies must end at least 1 millimeter before the neighboring teeth. This is from Hortzka and Bassetti. On single implants, this can be a problem because it leads to a lack of continuity between the dislocated fragment and the alveolar process. In these situations, we often need to graft to fill the gap. There also seems to be a vertical bone loss happening in these cases, and this is something that I see in my cases as well. So be sure to place your implants 1 millimeter deeper than what you would do normally. Now, contained defects with a concavity, B-type, are suitable to be regenerated by GBR. Curry plates will work as well here, but the morbidity, once again, from harvesting sites should be taken into consideration. So we go from this situation to this situation. In cases like this, ask for long-term stabilized barriers, typically titanium reinforced barriers or any kind of barrier. We know this from Mauro Merli, which allows, these barriers will allow a mobilization of the site to regenerate over a long period of time. And so we obtain cases like this. In type C defects, the last anatomical configuration, we have unconfined defects with very residual bone. We have these defects that lack medullary bone on the recipient side. This means that we need to ensure the osteogenic potential of our graft. We need to add the genetic input, the cellular information that will allow for a graft to mature into bone at such a distance from the alveolar crest. So inside the contour, inside the ridge, GPR is a very, very valid hypothesis. But when we are considering grafting outside of this ridge, then it becomes clear that the only option really that can achieve success in all situations, this will involve autologous bone. Yeah, so we need autologous, but autologous bone is not, all autologous bone is not the same. This is Rojo, 2002, on an experiment with 5 dogs. The premolars were extracted on these dogs. On both sides of the mandible, the buccal bone plate was removed and defects were produced. On the left side, a block of bioos was adjusted to the wall. In the contralateral side, a block from the ramus was adjusted to the wall. This, you can see it retained with a mini screw. And 6 months later, the biopsies will show that the only graft integrated, but underwent a marked peripheral resorption. 30% of the height, 50% of the width were replaced by connective tissue. Bioos's dimension, on the other hand, the dimensions will remain untouched and changed, but only a minimal amount of new bone, of actually new bone, is formed at the base of the graft. Here you see it on an illustration. And then again, this is the behavior you can expect from blocks, okay? This is from blocks, marked resorption in an autologous block, minimal bone growth with exemal blocking. Of course, this also depends, this is not illustrated here, but it will depend on the anatomical configuration, okay? You have different results when grafting with blocks, depending on the anatomy of the site to be reconstructed. And this is in line with clinical data reported by other authors. In the literature, we can find up to 40% resorption after 6 months, vertical augmentation with block graft in the mandible. Now, why is this? This happens because the cortical part of the bone of our grafts has actually very limited potential for capillary penetration, because first there must be osteoclastic activity for the vessels to penetrate. The clot does not penetrate the interior of the graft easily. The parts of the cortical that don't undergo osteoclastic activity become necrotic, but will live with the parts that are resorbed and that now have new vital bone. This is Cha comparing perforated bone blocks, versus non-perforated bone blocks, and is comparing the performance of these blocks. And the author will report a greater resorption in the solid block compared to the perforated ones, less vessels in the solid block and fewer cells. In the perforated, the vascularization, but also the volume maintenance, and this is very important, this is critical. Also, the volume maintenance is better, and this has all to do with the increased vascularization that the perforations enable. So, taking advantage of the fact that the cortical bone is very difficult to penetrate by blood vessels, and that the medullary bone is vascularized very quickly, Curie would propose the split bone technique. This is a very, very popular article by Curie, and rightly so, because it's the result of 3,874 bone harvesting procedures obtained from the retromolar area, proving that relatively large volumes of bone block graft can be retrieved from the mandible with a low complication rate? Could we propose the collection of bone from the retromolar area from this specific site? Well, this is the procedure itself. We usually perform an incision similar to the one we use on a wisdom tooth extraction, exposing the external alveolar ridge. This is a case where the bone is obviously abundant. We have a ledge of bone, if you will, and this is an important aspect because this anatomical natural configuration is something that really facilitates the graft harvesting. You can use small saws for this, micro saws for this, or you can use a piezo, as you see here in the image, in the video. And it's really a matter of delimiting a rectangle of bone with enough dimension for our needs, always taking care to be sure that we pass the outer cortical with the possible exception of the apical cut, which I really don't perform it all the way. To detach the graft from the mandible, normally I will use a chisel once all my cuts intersect. Here I'm making sure that there are intersections, that there is no cortical present. Otherwise, the harvesting will be quite difficult. This is me performing the apical cut, I believe. Yes. And once again, I don't really go all the way. You don't need to perform this cut all the way. The others, yes. The other three, yes. But this apical, not really. It takes a little bit more time to do this with piezo. It's also more safe. And here we are. You see me using a chisel, and now with some lateral movements, we harvest our bone from the retromolar area. We also harvest the medular present. Okay, so to ensure that we have bone that is easily vascularized, we need to obtain particulate bone, and we do this by scraping the cortical shells. I'm using a bone scraper here. I'm using a meta bone scraper. This is a terrific way of obtaining a large volume of bone. Okay, so we obtain this bone block, but then we modify it. We change its macrostructural properties, and we can really obtain a nice volume of particulated bone that we can then pack in our surgical site. And this being the result, obtain a couple of thin sheets of bone and a comparatively large volume of scraped bone. So this technique uses specific graft configuration in which thin cortical layers are used as autologous bone barriers that once you screw them at a distance, this will allow for bone formation inside. This is a typical arrangement for the anterior area. And here we have a typical arrangement for the posterior area. And what happens to this bone? What happens to this cortical bone? Well, this is non-vital. Okay, none of this graft will survive the procedure, the transplant procedure. Okay, and we don't have any bone that's really able to survive a graft like this. The medular part is easily to vascularize, so it's easier to form new bone there. But as for the cortical part, the amount of non-vital bone, however, will decrease significantly with the time of healing. This is a Coachella, and the results indicates that non-vital bone is progressively remodeled, but individual variations concerning the rates of non-vital bone remodeling are for sure present. So this means, so clinically it's possible to find cases where 3 months or 4 months we have complete vitality of the graft, In other cases, just take a little more time, as we see on this little graph at the right, at the bottom right. So here's a simple case, a couple of premolars missing the vestibular cortical in tooth number 25. We reconstruct the alveolar plane, creating a rigid container that we fill with scraped bone. And this is the results at 4 months. Here's another example, a little bit more challenging. We don't have all around bleeding bone that is really able to provide oxygen. 4 months later, you can see the implants inside the bone, bleeding bone, nearly undistinguishable from the adjacent bone. Another example of ridge augmentation at 4 months. Yet another example, this ridge is not wide enough for implant placement without the risk of thread exposure. A few months later, we can see the result of opting for a solution made up of autologous bone and rigid barrier. Another case where we are going from a 1 millimeter ridge to a platform where I can place my implants comfortably. Here's the 4 months result. A difficult anatomy solved thanks to the bone split concept. So we obtain these results routinely in every case. We get the same results, whether we're talking about simple cases or more advanced three-dimensional cases like this one or this one. So these are cases that I have recently made. Here's a simple case of a lower molar missing bone on the vestibular. This is something that that I see a lot in my clinical practice. It's a very common situation. And we extended, so what we did was we extended the incision from the molar to the retromolar area that allow us to collect a graft from that region. This is composed, of course, of a cortical and a medullary portion naturally. And after graft manipulation, we obtain this bone sheet, this bone blade that we immobilize at a distance and compact the medullary bone scraps inside. We always pay attention to soft tissues. A competent tension-free suture is intended here. Here are results at 4 months. We have bleeding bone and inadequate amount of bone for implant placement. Here's the treatment sequence. In some cases, we use a 3D printed guide to collect our graft to guide our implant placement. Here it's possible to see its perfect adaptation to the external oblique line. After our osteotomy is performed, we collect the graft, and often if we have enough primary stability, we place the implants in the same surgical act. As a final result, we obtain a new contour of the alveolar process. Very similar case here, again with a guide, which allows us to be certain to avoid any important anatomy and also to be precise about the amount of graft to be collected. Now, we have implant threads showing here where it matters the most, and we use the lower molar here to guide our graft collection. Not all guides must be large and bulky. Here we can see the osteotomy lines, the area where the graft was collected from. And here we see a perfect adaptation of the graft to our surgical guide. We obtain our bone particulated using the scrapers. We also manipulate the resulting bone blades. It is important that we leave no sharp edges, of course, minimizing the exposure. This is the surgical outline, and this is the interventions finale. 3 months, our implant is covered with new vital bone. A referred case for reconstruction and implant placement of a patient who suffered a hockey accident 7 years ago, tooth number 21 replaced by an implant, but now the implant has mobility, pause, and pain. So this is the radiographic result after tooth 21 was removed. So we have a 3D defect, and clinically, a few weeks after the extraction, this is the panorama. The soft tissue architecture has been maintained, which is nice. Unfortunately, We are in a worse situation in terms of bone availability. There is a three-dimensional defect that occupies also part of the palate. This was the graph that we obtained, and after the manipulation, this is the outline of the surgery. We'll be using here a screw of 1.2 millimeters, that 1.3 actually, that will hold and compress the two bone plates. We will fill this container with particulated autologous that is easy to vascularize. We can see some prominences and sulcular spaces being invaded. These are subject to refinement until we have blades that are really unlikely to expose. And we're ready to graft now. These are particulated and condensed graft in its place. These types of grafts are very difficult to be invaded by soft tissue, provided there is enough particulated bone and it is condensed properly. In this case, we try to mobilize the tissue as little as possible, otherwise we would end needing multiple surgeries in the second stage to reposition the mucogingival line as well to increase the volume. And this would be a problem, an aesthetic problem, obviously. We'll be still needing a soft tissue surgery, but not so aggressive kind of surgery. Let's put it that way. And this is a few months later. We still here we have it. Very convincing bone reconstruction from very little to a complete regeneration. We used a guide to place the implants and a little bit of soft tissue in place. But yeah, we're not always doomed to collect our bone graft from the ramus. Obviously, that does not add much to the morbidity of the surgery whenever we are working close to the retromolar area. But in many cases, collecting bone from the retromolar area means that we're collecting bone from a second surgical site. So I have been trying more and more to maintain my bone graft within the same surgical site. And this is what my friend Radolau Yadach calls the one wound concept.
Hello, Pedro. Thank you for invitation. You gave me 1 minute only for explain one wound idea. First of all, about the hard tissues. For example, here, we have to take care about the emergency profile. So we have to change the bone status. So any oscillating saw or piezo saw, you can split cortical bone on buccal side, move it up and fix it by screws. Green one is a graft. You can decorticate it here for better blood supply. Next one, that part can be moved here and fixed by screw. Next one, move up and fix it by titanium plate, or three type bone defect after extraction. That cortical plate can be moved here and fixed. Thank you.
So let's see some examples that could fit into this concept. This patient needed both her molars removed because they were impacted in such a way that would be very challenging to do anything else. But because we didn't want to end with a lot of bone removed from the molar area, we decided to execute the bony lid, thus limiting the bone removal to a minimum. We removed the impact teeth, preserving the bony lid as seen on the right. And we also scraped it in order to collect a large amount of easy to vascularize bone. We then proceeded to reconstruct this area, securing the cortical shell with some screws. And here you can see the final result. Here what we have is a very atrophic first quadrant in need of a sinus and also some kind of horizontal graft. You can see a not so easy case, yet we went for it and used the sinus window. You can see the Schneiderian membrane reflected along with a collagen plug. This will be assuring that no biomaterial will be spread through the sinus cavity. The sinus was grafted with beta TCP, and we used the bony lid as a rigid barrier, stabilizing it to the crest. We are collecting bone from the tuberosity here and fill this site, but we don't have enough bone, obviously, to fully fully fill the defect. So we used also a combination with xenograph, beta DCP to be more precise, and we secured the surgical site passively. Here's our results 6 months after. And this is an interesting case. It's a very atrophic ridge. In this case, we had already collected a graft from the retromolar area here to reconstruct the maxilla. So what we decided to do here was to keep ourselves within the wound, within the same surgical site, and collect bone apically to the crest. You can see the medullary content exposed after collecting the bony lid. This is the collected bone, the harvested bone. And after scraping and shaping this collected bone, we decided to screw it crestally, augmenting considerably the crestal area. This is before surgery, and this is after surgery, and this is 6 months later, and we have a new cortical and sufficient width for implant placement. This is a very nice X-ray right here. There you go. This is the clinical. These are the clinical pics. Another interesting case, we have a post-extractional case. We can see that we will be left with a not so big of a ridge. We will be grafting the sinus, also extracting teeth number 28. The patient was complaining of pain in that area. Here we can see the antral artery in our way. And for this case, we went with an unusual approach. We decided to approach this sinus palatally. So we can see a vertical incision on the canine area, an area where the dimension of the palatal artery is diminished. And we accessed the sinus through a rectangle made by piezo, extracted the lid, and as you can probably see, the palatal bone in this case, in this area, is thick, much thicker actually than the bone obtained from the vestibular side normally on the previous or in the previous example. So this is what we obtained. And this is the vestibular view. We also extracted tooth number 28, splitted the harvested bone. This is the minuscule going through it. This is the remaining off, created a contained defect. And of course, this stability TCP for the sinus. We could use xenograph as well. Scraped bone, dentin graft, and again, the palatal view now with the sinus performed. Bony lid in place, no screws needed on the plate. The thick palatal mucosa will keep it immobile. Typical look immediately after grafting. Radiographic view here, and ready to place an implant. So as we can see, there are several reasons why one would choose this technique. The advantages of the demonstrated technique include bone that is 100% autologous. This can be nice for the integration of the implant. Fast regeneration, cheap, does not have animal origin, and reacts very nicely when exposed. As a negative point, of course, the fact of being invasive and being technically demanding. It is not perfect. For that, we will have to transform the two elements on the right just enough that they might belong to the left column. Thank you. Are you guys still there?
Beautiful.
Okay, so when you can start now recording the questions.
Okay, thank you, Dr. Pedro, for your excellent presentation. And thank you again for accepting our invitation to this meeting. It is always a pleasure to have you around sharing your knowledge.
Likewise.
Thank you. Well, going deep in your presentation, you start by the beginning. You start to say about diagnosis. How do you evaluate the amount of bone that you need? I think you do it, this evaluation, instead of the bone that is present, you need to evaluate the amount of bone you need. Can you?
The amount of bone that I need to collect?
That you need to rehabilitate the case.
Okay, well, I plan my cases digitally. If that's the question, I plan all my cases digitally, so I know in advance where should the crown of my tooth be, and from that position, I plan the position of my implant, and then I will know how much bone I will be needing. You can then transpose that information if you want to keep in a digital environment. You may want to transpose that information and design a surgical guide to obtain your graft from the ramus. Look at the Stabula has shown us this a few years ago, and from once in a while I do that. So that's a very, if you want to be precise about the amount of bone that you need to harvest, that's a good way. That's a good way to do it. You could do it a little bit more analogically, as you could print the mandible and you could play around and until you reach a conclusion about the amount of bone that you will need. But typically that's what I do. I place my tooth, then my implant, then I will know, okay, I need to have bone up to here. Okay.
Hey, thank you. Beautiful. Yeah. We need to restore the teeth, not the bone, just bone.
Yeah.
Yeah. Thank you.
For sure. For sure.
Thank you. Thank you. I noticed from your presentation this day and the other days that I saw you, and I saw you often, as you know, you always try to get native bone around the implants. Using different techniques, expand the crest, regenerate the crest with cortical plates. At the end, how much do you try to get around finally, at the end, how much do you try to get around the implant to promote bone stability? And since natural bone can go for some resorption, do you consider to use slow resorption biomaterials to stabilize this dimension?
Yeah, well, look at the Stavla, he uses it, yeah, and I don't use it. If I were to use it, I would use it as he is using it, which is to graft the site 3 months after using this cortical plates approach. I wouldn't do it at the same time. I have tried to do it at the same time, and it just doesn't work. It just gets resorbed. Any graft that you put on top of the cortical shell will get resorbed completely. You may have integration of the xenograft on the sides laterally to the graft, but not on top of the cortical. So that I would do. If you're in a great need of volume, this might be a great idea to place some xenograft to make sure that we have volume. But that's all it is. You will have a hard time. If you have exposure in a situation like that, I believe that you will have a hard time maintaining all that volume. Myself, I prefer when I need to have a lot of volume, not specifically for the implant, but a volume, let's say, to have a better, a more aesthetic integration of the ridge. I would prefer to use soft tissue, because if you're using soft tissue, you will have the advantage of minimizing the chances that you will have recession. Okay, so between these two approaches, I am much more leaning to the soft tissue approach. As for how much bone I need around my implant, I would go for 1 millimeter, 2 millimeters of bone, but I'm talking about particulated bone that will be easy to vascularize. What you don't want to do is having that outer cortical shell immediately against your implant, because your implant is obviously a vascular surface, and it will just be really hard for the to have vascularization on that particular site. So probably chances are you're going to get a little bit of resorption there.
Yeah, I do agree with that. And you touched the point of revascularization. Bone needs to be to get new vascular income to get integrated with the native bone. So the graft must be revascularization, the process within. What do you use as an approach to favor this new vascular network or net to get inside the cortical bone? And
I think you understand.
Do you use?
You're juxtaposing, yeah, you're juxtaposing the idea of cortical perforations that we use in GBR. Is that it? Because typically, okay, in GBR, you would typically in GBR perform some micro perforations in order to access the mesenchymal cells, etc. Yeah, and that makes sense, no doubt. But here, you see, the process, the biological process is a little bit different. What you have is dying cells. Okay, you have this graft, you have this scrapes, and these are cells that are dying. But when they are dying, they are signaling BMPs. They are telling all the pluripotent cells in the area that this will be a nice area to regenerate, taking into account the kind of cells that are dying there. And so this is a repairing process, and that's why it works. And that's why it works a little bit differently than when using xeno. That's why you don't need to use a membrane. That's why the vascularity, the access to the mesenchymal cell is not so important, because it's other kind of process that is going on. So clinically, I find no difference in the literature. It's conflicting the literature. We don't know exactly if you absolutely need to make these perforations or not when using this technique. And I find no difference in my clinical practice between making these perforations or not. Okay, so what do you need? What you need absolutely is to have a lot of particulated bone condensed. This seems to make the difference, really make the difference.
Yeah. Finally, still within this topic, do you get better results with the preservation of the periosteum, the integrity of the periosteum? Your suture technique, your suture technique must be very precise to get your soft tissue close to each other, no fenestration, no dehiscence. You must not get dehiscence at any time, don't you?
Well, soft tissue manipulation here is fundamental, is very important. Flap manipulation, but this goes for all the regenerations. Okay, if you're doing GBR, it's the same thing. You need to know how to really perform flap manipulation, whether the lingual or the vestibular side. You really need to get that flap without any kind of tension. But there are a series of procedures that I do on the second stage surgery. Apical position flap, vestibuloplasty, and free gingival graft typically. And this has to do with the way that we suture, because you want to evert the suture whenever we evert our flaps, because whenever we have eversion of our flaps, we seldom have exposure, okay? But this is for the vertical, this is for the posterior, okay? Whenever I'm doing anterior sides, I don't want to do that, because I'm left with no keratinized tissue, and then I'm going to have to perform a free gingival graft or an apical position flap, and it just doesn't. It ends really nicely from a bone standpoint, from a soft tissue standpoint, it's not aesthetically pleasing. Okay, so I am making sure that I have no tension, but I don't perform an over-mobilization of the flap. Okay, this is not the way I do it right now, and I really seldom have exposure. I can, however, perform soft tissue augmentation at the same time when I'm doing Curie graft. Just a little bit of connective tissue against the bone suture to the vestibular flap. I'm not doing it previously. This is something that I would do if I were to use titanium meshes, etc. But I really don't like to do it because it's another surgery for the patient. So I would really like to avoid that. But I do agree that it really makes the tissue thicker and less prone to exposure, no doubt about that.
So you already asked to my next and final question. So I want to thank you at the end of this beautiful presentation for sharing with us these beautiful cases and this comprehensive and very objective presentation.
Thank you.
Thank you so much.
Bye.
Bye.
Take care, guys. Bye-bye.
Okay. Friends, we are again for the second part of our presentation, our meeting. This second part will deal with soft tissue management. And we are very pleased to have Dr. Sofia Aroca, who will talk about this issue of the soft tissues and the choice for Mucoderm and when to apply it and the criteria for the success of this technique and with this biomaterial. So thank you very much, Dr. Sofia Aroca, to be with us. And please, you have now your time to do the presentation. Thank you for your acceptation of our invitation. Thank you.
Okay. Hi to everybody. I really, first of all, I would like to thank Botis for giving me the privilege once again to share with you one of my preferred topics. I would like to talk about a specific technique. It is the modified coronary advanced tunnel technique for the treatment of multiple recession type defects. But what I would like to give you today, to share with you today, is not only the technical part, but also what I believe that some thought, clinical and biological principle of this wonderful technique. Therefore, let's go to see how this technique must be performed. I am talking about the modified coronal advanced tunnel technique. Maybe you know, if you are interested in mucogingival surgery, you know that we have several surgical techniques to treat multiple recession type defects. Therefore, and even more, we have several types of tunnel techniques. That's why I always underline, I'm not only because I'm repeating myself, but I have to underline that this technique is a specific technique which is called a modified tunnel advanced technique. Therefore, just let's have a look how you should perform this technique. First of all, you start, as you can see in the screen, that you start to elevate the flap with a micro elevator, just a micro elevator. As you can see here, I stop a little bit because these technical steps are extremely important. Does not mean, when I am telling you that you can elevate the flap with a micro elevator, does not mean that you cannot do with a blade, but you will understand why. For me, it's extremely important to respect this clinical advice. to elevate the flap with a micro elevator. You start, as you can see in the screen, you start by the gingival sulcus and you go deeper vertical. At this time, you don't touch the papilla because you were talking about the tunnel technique. Therefore, the papilla is kept intact. Therefore, you can see that you do, and you have really a very tight contact with the bone or the root surface. And afterwards, you elevate the flap, you connect all the pouches, vertical pouches, and you start very, very, very nicely, very gently to cut, as you can see, the fibers from being on the mucogingival line, of course, because it will, this gesture will allow you to advance in a coronary position without any tension, this tunnelized flap. And afterwards, in order not to damage the gingival margin, you perform a root planning as you are having a look here. Afterwards, you prepare, of course, the tunnel at the end, and you start to harvest the connective tissue graft from the palate, and you can use the technique that you really prefer. In this case, I am harvesting the connective tissue graft from the palate with a single incision technique according to the description of Utzeler. Now you can see that the connective tissue graft is about to be harvested very nicely from the palate. It is the deep layer of the connective tissue graft, but if you are in the most distal part, you have a very good quality of the connective tissue graft. Afterwards, you place under the tunnel with the help of the sutures, and you can see now that the papilla also there are elevated very nicely from the underlying bone. In this case, we use the connective tissue graft only in some of the biggest recession, and maybe we will see why it was this choice. And afterwards, we cover completely, and the suspended suture around the contact point allow us, of course, to be extremely stable for the healing phase. Now, as I mentioned before, I will share with you important clinical and also biological thought and principles about this technique. First of all, we have, according to my experience, we have 4 important steps that you have to really keep in mind and to respect in order to be, of course, predictable in your treatment. First of all, you have to preserve, and you have to preserve the papilla completely intact in order to ensure its integrity. Why it is important? Because of the vascularization, of course. The full thickness flap elevation will allow us not only to be stable, but you will see why it is really important, the full thickness flap elevation in regards of the recession type defects itself. Also, we know that we can, according to the phenotype that you have apical to recession, you can selectively use the connective tissue graft. And you know that the gingival phenotype is the clinical expression of the width and the thickness of the gingiva. And also you will see why it is extremely important to fully cover the connective tissue graft in these cases, and never go further than this. If you really keep in mind these 4 steps, I think you will be extremely sure in your clinical knowledge and your clinical results for when you use this technique. First of all, the preservation, as I told you before, the preservation of the integrity of the papilla means that you keep your papilla intact and you elevate fully. because you have several studies showing you when you cut the papilla, you, of course, you damage the vascularization. And here just what we can illustrate a little bit with one of those studies, that when you elevate the full thickness flap and you cut the papilla, the blood circulation is extremely reduced, and it takes very long to become to the normal state. And for instance, in the interproximal area, you have is last 7 days become really normal blood supply. Even more, the tunnel technique is extremely important to think when you can apply this technique. And if you think to the papilla, of course, if you raise or you place an incision in a thin papilla, you can really have an adverse effect. Therefore, keep just that in mind. And as I mentioned at the beginning, when you were looking at the video, that the papilla is raised in order to keep really the integrity. You raise at the end of the preparation of the tunnel. First, as I mentioned, you go vertically, and when you finished preparing all the pouches according to the number of the recession that you will treat, of course, you will connect at the base of the papilla, these vertical pouches, and at this time you don't touch the tip of the papilla. Why? Because if you start to prepare your tunnel by the tip of the papilla, you will have a very easy. It is very easy to go under and to elevate the tip of the papilla, but also you run the risk to cut the papilla. That's why it is just really. I will give you through the course of this lecture a very much clinical tips, or a lot of clinical tips, and go further. Full thickness flap elevation. Why it is important to really respect that, not to damage the gingival margin. Why? Because you know, when you have a full flap, what you have in the inner part of your flap, you have the periosteum. And the periosteum is extremely rich, not only in vascularization, but also with cells. You have there all of those cells that you need in order to recreate a clinical attachment over the vascularized root surface. Therefore, it is extremely important, and that's why from the beginning of your clinical gesture, to go under the flap with a micro elevator, I think you can control much better that movement, and you can really pay attention. You can really pay attention to not to damage even the border of your gingiva. Just I want to share with you this extremely interesting article, and I advise you really to go to read. Look at the title. It's extremely interesting because we are clinicians, but the biologically guided flap stability. They compared, of course, not in these studies, not about the multiple recession, but just the think back to the biological principle. That means to keep the periosteum into the flap, in the part of the flap that it will be moved coronally into place over the root surface that it was there, and you know that is an avascular surface. Therefore, they compare the flap, the full split flap technique with a split flap technique to cover the recession. RT1 type recession type defects. And of course, they found that to preserve the periosteum in the most important part, of course, of the flap, it was extremely correlated to get a complete root coverage. And for that reason, as I mentioned before, that the best way to respect that is to elevate with a micro elevator, as you could see also in the clinical movie. And the full flap elevation beyond the mucogingival line. Okay, and afterwards you cut very nicely, very gently the muscle fibers or the collagen fibers in order to advance coronally the flap without any tension. Let's go further. The selective change of the gingival phenotype, as I told you before, that never forget what does mean gingival phenotype is the clinical expression of the width and the thickness of the gingiva. And you know, most of the old techniques, and even in the tunnel technique, we usually go for the connective tissue, to place the connective tissue graft over all the recessions. But now we know, because we could read in the literature, you can use the connective tissue graft according to the gingival phenotype. What does mean? That you can select just the site where the phenotype is thin, and just in that site you can use a piece of connective tissue graft. What is important beside the result, that you, first of all, you can be predictable because you evaluate clinically, from a clinical standpoint, where you can place the connective tissue graft. And moreover, you can be predictable, because with your clinical evaluation, you can anticipate the result that you will have. And third, that the literature, it was demonstrated that you can get more, the aesthetic result can be improved, of course, because you do not have this huge connective tissue graft appearance that you can sometimes observe in some clinical cases. Therefore, these two wonderful articles, they conclude that the connective tissue graft can be only apply to certain sites where the gingival phenotype is thin. Therefore, I think is quite clear. And since it was proved with another technique, that it was not the tunnel technique, but you could see that these two wonderful studies came from the Italian groups. Therefore, we decided also to make a clinical follow-up in cases with the tunnel technique, applying the selective, the specific use of the connective tissue graft. Is a little bit long to tell you. But what was the evaluation, the clinical evaluation that we based our decision? It was that we measured the width of the keratinized tissue, and therefore I will show you some result. It was published, by the way, and we for multiple recession, and we had 36 multiple RT1. It is extremely important to underline that only the specific use of the connective tissue graft is on the RT1 type defects, also for the technique that the multiple coronal advanced flap technique is also concerned only the RT1 recession type defects as for us. Therefore, we in some sites where the keratinized tissue width was more than 2 millimeters, we did not place connective tissue graft, only in the sites that we had less than 2 millimeters of the keratinized tissue. And we, of course, what we obtain, that we obtain more or less the same results for those sites where the connective tissue graft was placed compared where it was not placed. So the percentage of the complete root coverage was the same for both. And therefore, we conclude, of course, it was a clinical follow-up. It was not a randomized control studies, but I think we should start by that, and we are preparing, of course, randomized control studies. And it is this technique, applying the specific application of the connective tissue graft according to the phenotype with the tunnel technique, is also an effective way of obtaining complete root coverage, as long as the recession type defects are RT1 recession type defects. And just let me go step by step, because I told you that I really want to give you a lot of clinical tips. And the case that you saw in the movie before, can you see that we had multiple recession, but not only multiple recession, therefore soft tissue defects, but also hard tissue defects. And you can see that you can observe at the level of the canine that we have non-cervical, non-cariocervical lesions, excuse me. And first of all, that they were treated, and in order to have at the end the suture suspended around the contact point, I asked my student, because this case that I am sharing with you, it was performed at the university with my students. Therefore, I asked them to close the contact point. And that's why you can see that the contact points are closed by the composite spot. Therefore, go step by step. You elevate the flap with a micro elevator in order to keep intact the periosteum into the flap, because do you remember that this part will come really over the denuded root surface, and that's why you have to have a look how the gingival margin is really not damaged at all. Afterwards, you go very gently beyond the mucogingival line to take here you can see the collagen fibers, and you cut very gently with a blunt curette, of course, because you are scraping a little bit the inner part of the tunnel. And afterwards, why I'm showing that the root planning is performed after you elevate the flap, because that's also, you have the flap, that the tissue, the soft tissue, you can elevate a little bit here in order to go into the sulcus and to make your root planning. And in this way, you can see that also you do not damage the gingival part of your flap. Therefore, you know, there are very small tips that you have to keep in mind in order, improve your clinical knowledge, your clinical skills, and at the end you connect at the base of the papilla, you connect the pouches, the vertical pouches, and you at the end you elevate the tip of the papilla. And of course, the connective tissue graft that we choose also to place specifically in the sites where the phenotype, the keratinized tissue was less than 2 millimeters, or the phenotype was a little bit thinner than on the other sides, we place with the help of the suture, the connective tissue graft. In this way also, I didn't mention before, but which is the benefit of this technique. As long as you can do that, as long as you evaluate that there are you are facing RT1 recession type defects. Of course, you reduce the morbidity of the patient because you do not harvest long piece of connective tissue. But also you can see that in two sites we place this connective tissue graft with the help of the sutures, as you can see here, and the tunnel is very without any tension, and very easily you can move coronally to cover completely. And you in order to advance coronally, the suture is at the level, horizontal matrix suture at the level of the papilla, paying all very much attention to keep your needle in the keratinized tissue, as you can see, and go. You pass your needle, you go, you cross your suture, and you go palatinal. Afterwards, you come back buccally and you close your knot. Please pay attention how nicely and how the good healing is going on, and through the course of time, from the beginning until I think is 12 months. And you can see that the connective tissue is quite stable in the new position. A closer view, and before and after, at 1 year of the result. Therefore, just I think now for you is much clearer, and even later you can see that we can still keep the gingival margin even more than 1 year result here. Therefore, as I mentioned you before, and I really think must be clear in your mind, that the selective use of the connective tissue graft is predictable for when you are facing RT1 recession type defects. When you are you have RT2 recession type defects, because if you know the literature, you know that this technique is predictable for RT2 multiple recession type defects as well. A very long time ago, in 2010, we published the first RCT showing you that. And of course, in that case, the dimension of the connective tissue graft must be adapted to the number of the recession. Don't try, not because it's now fashion to use the specific use of the connective tissue graft that in this kind of cases you use, because you need much more support, not only buccally, but also interproximally. Therefore, you have to adapt your connective tissue graft to the number of the recession. And if you do not have enough, we will see how you can solve that problem if you do not have enough connective tissue grafts in order to apply. The full coverage of the connective tissue graft is extremely important, because as in the literature, everyone mentioned that one of the most important indication to go for the treatment of multiple recession is to improve the aesthetic of the patient. And but if your goal, of course, must be the goal. If the patient is demanding that, you cannot reach aesthetics without a full coverage of the connective tissue graft. Look at that. Here you have uncovered part of the recession. The phenotype is quite thick. You can see which is the result. Of course, we improve the quality of the keratinized tissue, but not the aesthetic. And even more, if the patient has a little bit gummy smile, of course, is not the best way to finish your surgery. Just let me show you what can in this full arch recession type defects, RT1 recession type defects, we use the tunnel technique, and we fully covered when we place the connective tissue graft. We fully cover it, and you can see that the results are a little bit more aesthetic. It is not only because it was done by my hands, but no, because I really applied what I think are extremely important steps from a biological standpoint. And you can see also through the course of time, we start from this situation, and the patient at more than 3 years, the stability of the gingival margin, but also the blend of the tissue is the texture of the tissue is also visible here. That is really aesthetic. Let me share, when we were talking about the predictability of the tunnel technique in this extremely complex case. It will be my last case. The complex case, this patient was sent to me not only for the treatment of multiple recession, but the 2-1 teeth was extremely resolved, and with the external resorption. And the dentist of the patient wanted to place an implant, to replace the tooth by an implant, of course. But the problem was the aesthetic, because the patient was complaining not only about the tooth, but the aesthetics. You can see that this tooth is rotated. Therefore, when you have a rotation, the first evaluation that you have to do, if the patient comes to you because wants to improve the aesthetic, you have to really start your clinical evaluation with the most data that you can. Here, when this central incisor is rotated, therefore you can see that the major distal measure of this tooth is less than the neighboring tooth. Therefore, here, my colleague wanted to replace, at once I told him that we have to go a little bit, maybe for a very, very, very gentle orthodontic treatment in order to enlarge the measured distal distance, in order to have the same morphology of the neighboring tooth, as long as we can do that, of course. But the patient was extremely demanding, because she told me that she really wants to improve, and she came to me because she knows that I can do the recession coverage, the treatment of the long teeth, without harvesting connective tissue graft from the palate, because she does not want, she's really scared, and she wanted to have that. If I can do that, she will be very pleased to go to the treatment with me. And of course, I proposed her. But what it was my first clinical thought, that I have to have soft tissue in order to go through to all the the more complex clinical steps. Let me share with you more than that. You can see that the 2-1 was really resolved, not only resolved, but you have also the buccal bone plate missing. Therefore, I knew that I need not only soft tissue, but also I need bone. And my first step was to reconstruct the soft tissue, since the patient was extremely scared about the connective to have connective tissue graft harvested from the palate. I used the mucoderm collagen matrix, and you can see through the tunnel that the tunnel internalized flap, this very easily to use this the mucoderm. Okay, we covered completely the matrix, even more the matrix than the connective tissue graft, because we really want to keep intact and to protect completely the collagen matrix in order not to have any adverse effect. Of course, it's not really elegant, the most elegant way to suture it, but is the tunnel technique. Therefore, just let me show a little bit more how this patient healed. The early healing phase, it was like that. Therefore, you can see now that I decided to keep, in order to have some support for my soft tissue, the 2-1. The patient knew that it will be extracted, of course, sooner or later, but I wanted to have a 3-week cicatrization, you can see. And at 6 months, please pay attention to the neighboring teeth, how the soft tissue healed. Of course, in the meantime, we started with the orthodontic treatment in order to enlarge a little bit the place for the 2-1. The tooth was extracted. I did the socket preservation procedure, but the socket preservation, how can you see here that how really was extremely, I was secure to work with the connective tissue. And for this time, the socket preservation, the technique, we are not talking about how to go through with this technique, but for the time being, it was more than 6 months that I was following the patient. I could convince her to take a little bit of the connective tissue graft from the palate, but the most important thing was done with the recession. And just have a look at 7 months after the first surgery, how the soft tissue healed. And you have 3 weeks after the extraction, and we go 2 weeks and 3 months after the extraction. You can have a look the maturation of the tissue. 6 months after, of course, I decided to go for the replacement of the tooth with an implant and a very thin connective tissue in order just to support, because you could see that the thickness of the tissue was given by the collagen matrix that it was used at the beginning. Not a very nice tooth was temporarily replaced, but you can see the maturation of the tissue, the neighboring tissue. You can see how the texture is, and now what you are looking at now is the temporary crown, 1 year, because we really wanted to wait the most, and this is the temporary crown. You can have a look that we could preserve, of course, the bone. We could reconstruct the bone very nicely. And after 1 year, we went for the final crown, prosthetic crown, because everything was mature. But have a look the stability of the neighboring teeth. And we started from this situation in your left side, and on your right side, you can see the 3 years result. Okay, now we have maybe too much tissue on the implant supported crown. but I think through the course of time it will be okay. But the patient is extremely happy, and also us. But what I can tell you that here you can see the stability, also the bone, and of course the soft tissue. You know that if you have stability of the bone, you have stability of the soft tissue, and vice versa, of course. And therefore, what are the main biological and clinical principles that justify the use of this technique? You have to know that you maintain the blood supply because you preserve the integrity of the papilla, and also you keep the periosteum into the most important part of the flap, which will be advanced in a coronally position. And you increase the probability of complete good coverage, even if the most complex cases, and not only using the connective tissue graft, if your evaluation is extremely clear and you have all the steps clear in mind, you can also have some alternative to the use of the connective tissue graft, and the complete good coverage is of course one of, you can be sure that you will have that result. And the aesthetic, I think I proved that even using collagen matrices or connective tissue graft, you can improve the aesthetics as well, if the main demand of the patient it was that. And with that, I really thanks that you shared with me this time in order to listen to me to talk about one of my preferred technique. Thank you very much.
Thank you very much, Dr. Sofia Roca, for your magnificent presentation. I would like to put you some questions that arise from your presentation. And can you tell us about what conditions do you consider essential for regenerative success with Mucoderm?
Thank you very much for the question. Is not only because it is usual to tell that, but it's extremely interesting question. I think, as I mentioned, you have to really evaluate the clinical situation. And I usually tell to my colleagues, and even more to my students, that any of the product that we use is a miracle. You will really have success if you know when and why you use it. For instance, for this patient that I shared with you, the last patient, I knew that I can, this kind of recession, RT1 recession type defects, I knew that the same clinical result that I would have had if I would have used the connective tissue graft. Therefore, for me, what are the conditions? The condition is in your mind, the clinical evaluation. And with a right clinical evaluation, you will use the right matrix, as in this case, the Mucoderm. And even more, the Mucoderm, you know, because if you do not have any experience in the collagen matrices, the Mucoderm is extremely easy to use. It is very pleasant to use it. Very pleasant because it remain entire. You can place under the tunnel without any problem, and you keep intact all the matrix, and really you feel that from a clinical standpoint it's very easy to use. But first of all, that is the technical part. The first of all is your clinical evaluation.
Thank you very much. Another question is, what is the necessary time that is recommended to wait after a regeneration that has relapsed again to proceed with new interventions of tissue manipulation and or bone regeneration?
What I show you, I think the right time for everything is depend. For soft tissue is 6 months. Soft tissue is 6 months, but if you are using for bone regeneration, I think between 6 and 9 months. But for soft tissue is 6 months. 6 months, really, 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 very strictly 6 months.
Well, thank you. The last question, it could be around peri-implant regenerative procedures. In this case, do you consider the application of Mucoderm on the metal surface of the implant or the abutment to be a determining decisive factor for the success of this procedure? Would you indicate the Mucoderm for perimolar regenerative, and if so, in which conditions?
For me, can be really used in a predictable way if you augment the volume. If you have, we are facing in implant surgery, we are facing a lot of problems, not only the recession, but also the mobility of the soft tissue, and also the volume deficiency. And when you are facing volume deficiency, I think is the right indication for the use of Mucoderm. But for recession coverage around implants, I think must be much longer to demonstrate in which way, which is the surgical technique that can give you a positive result. And that's why I do not want to tell that you can use. I think it's much more comfortable for the recession coverage around natural teeth, and for volume augmentation around implants. Yeah.
Very nice presentation, Dr. Sofia Roca, and also your explanation about the questions that we have to explain this technique. Thank you once again for your presentation. We will proceed and carry on with the second, this soft tissue management with Dr. Gonçalo Assis. He will talk about the natural option with soft tissues, autologous soft tissues. So, Dr. Assis, thank you very much for being here with us, and it's my pleasure to once again have a meeting where I can learn a little bit more, always with your presentations. Thank you very much, and you have some minutes to explain us why, when, how to use soft tissues, autologous soft tissues grafts, and in what situations. Thank you very much, Dr. Gonçalo.
Thank you, Professor Tandela, for these very nice words, and also for the invitation to be here. For sure, this is a very interesting topic, and I'll do my best to explain how do soft tissue management and the role of autologous soft tissue in soft tissue management as a whole can apply. For me, it's also a great honor and pleasure to share this forum with Sofia Roca, with which is who is a very distinguished periodontist in our field, and has made very important contributes in terms of research and knowledge to this area. So for me, it's a great pleasure to share my experience and correlate it with her experience as well. When we talk about soft tissue management, we always want to solve some kind of a problem. In teeth, we have gingival recession. That can be in multiple teeth, can be a single recession, but also nowadays we have also soft tissue deficiencies around dental implants that are also very important. During this presentation, I'll try to do an overview of both indications for both teeth and implants of autologous soft tissue management. And I hope that I can describe in the small amount of time that I have to share this presentation with you a little bit of my clinical experience and an overview of the options that we have nowadays. When we think about soft tissue management in periodontology, even if we think about dental implants, we always think about the first techniques that came to place in our practices, and we also try to adapt them so we can use them around dental implants. The most described and ancient technique, it's the coronally advanced flap, described by Zucchelli and De Sanctis. Also, we have a lot of tunnel grafting techniques and its variations and modifications. We also have other pedicle flaps, not free flaps here, which where we can use a laterally positioned flap, and we have the very ancient free gingival graft that was described a lot in the last century in the 50s. So there are a lot of options. Of course, these aren't the only ones, and we have also other options, and those options include also soft tissue graft substitutes that we brilliant have heard about them by Sophia Rock. First, the coronally advanced flap, and we'll try to cover some principles of these techniques. The coronally advanced flap was described to cover recessions, cover a denuded and an exposed root. And in this technique, we create a new papilla that we call a surgical papilla, and we advance it towards the anatomical deepitalized papilla. When we do this movement, what happens is that the cervical margin and the gingiva apical to the recession also comes forward, and it is advanced coronally, and it reattaches to the root, and it covers. So of course, everything has to be stabilized using a very gentle and delicate technique, surgical technique, and stabilized with sutures. And this is a very interesting technique, and we can use even without a soft tissue graft here, if we have a good periodontal phenotype apical to the recession. We can use the same principles around dental implant, and we can do it as a matter of fact during implant placement. Here we see an implant placement with a rolling flap technique that aims to compensate for the horizontal deficiency of soft tissues on the buccal side of this implant. We deepitalize the epithelium, we stabilize the rolling of the flap with sutures, and this is a very easy and straightforward way to cover these horizontal deficiencies very easily without resorting to any type of graft outside other than the soft tissues that are already present in the area. So in this way, we can compensate in dental implants also with the soft tissue that are around, that already present. We can compensate for a lot of problems, and we can do that in multiple indications. What we know is that periodontal phenotype, when it is very thin, it is associated with the risk of gingival recession. And we also know that a thick periodontal phenotype is associated with gingival recession prevention. So all these techniques that we talked about before, in most of the indications, they are associated with a connective tissue graft or another kind of graft that aims to thicken the periodontal phenotype, because we know from the literature that we have to have a thick periodontal phenotype, and also we have to have thick tissues around dental implants to prevent bone loss and to have stability around our dental implants rehabilitations. And this is very important for periodontal health also, but for also periodontal stability and tissue stability and bone stability around our dental implants. So we aim to reconstruct the soft tissues in both teeth and implants with some kind of graft, something that we add to the surgical area that makes our results more predictable and more and those results are more stable throughout time. So we have here a single recessions of an upper canine, and we use the same principle of the coronally advanced flap. We design surgical papillas that we advance towards and deepitalized anatomical papillas, and by doing this surgical manipulation management, we end up advancing also the margin. Since this tissue was very thin, we added also to the surgical area a connective tissue graft that is stabilized with sutures, and over this graft the overlying flap is advanced and stabilized also with sutures. We have a very good early result here at 1 month and a very good stability in 1 year. And also here we can see some kind of a modification of the periodontal phenotype by the graft itself, which is also that is very characteristic of autologous substitutes. Around dental implant, usually we have, and here you have a delayed approach, an implant placement in an already healed ridge, and we can also add a soft tissue graft, here a connective tissue graft, inside our flap to thicken the tissues, and both in terms of aesthetics and health, it will become much more stable. We can use also soft tissue grafts around immediate dental implants. We can use it with an open flap approach. We always have to open this flap partial thickness, so we leave some connective tissue and periosteum to suture and revascularize our connective tissue graft. But usually nowadays we use soft tissue grafts around dental implants in immediate dental implants with a closed approach by stabilizing our connective tissue graft inside the socket. What this gives us is a compensation by soft tissue graft of the expected collapse of the alveolus and the dental socket. Here we have a very nice result already at 2 weeks. We have here an extraction, immediate implant, and immediate loading protocol. And we have this stability at 3 months, and we can see that we can reconstruct the width of, and we can even compensate a compromised socket that we would expect to have a very big shrinkage of soft tissue, and we can compensate it with the soft tissue graft and end up with a very pleasing aesthetic result and a comfortable result for us, because now we know also that soft tissue thickness by the literature is also very important for dental implant stability. A more compromised socket we can also treat with this protocol, and we can even use soft tissue to compensate for a type 3 socket where we extract the tooth with a gingival recession. We place the implant immediately, and we do immediate loading if it's applicable and we want it and has an indication as clinicians. And this can compensate for the shrinkage that we would expect by extracting a tooth with a gingival recession and placing the implant immediately. Of course, we try to fill the gap with the bone substitute, and we use this double layer approach also with the connective tissue graft. With this, we can achieve a lot of goals on one single surgery, which is to improve soft tissue, extract the tooth and place the implant with immediate loading. And here we see the result at 3 months with the provisional, and the patient will now advance to a ceramic structure in this area. But not all grafts are the same. Of course, when we talk about autologous soft tissue graft, there are a lot of different grafts that we use with different indications. We have a free gingival graft that it's usually harvested from the posterior palate, and we have a connective tissue graft that's usually harvested with a 1 or 2 incision techniques on the anterior palate as well. And both techniques and the combination of them will be able to deliver us very different soft tissues. Here we have a deepithelialized free gingival graft that will give you a lamina propria tissue. Here we have a tuberosity graft. Here we have a connective tissue from the anterior palate using a 2 incision technique. And here we have the tissue that we can harvest from the anterior palate using a 1 incision technique. All of these tissues have very different properties and very different indications. So one goal that I had with my presentation was to show you that not all autologous tissues are the same, and they have different uses. With the 1 incision technique, the tissues that we try to harvest are the deeper tissues of the palate, with or without the periosteum, but we'll have a very vascularized and sometimes with fatty glands and tissue that we can use for some indications with the connective tissue graft, both on teeth and dental implant soft tissue management. It's usually a tissue that integrates very well aesthetically, so I use in my clinical practice this kind of tissue a lot in the aesthetic area. We use this 1 incision technique. Is usually a technique that allows us first intention wound healing that is very uneventful for the patient. Of course, if we try to improve this technique by doing different incisions in different areas to allow also to have some connective tissue remnant in the donor area to allow for primary intention healing, the results in the donor area, and it's very important to take care of this donor area because it's usually a complaint of the patient if we don't treat it properly. These are one type of suturing of the palate. Usually I'm keen on using these compressive sutures that also allow the patient not to bleed during the healing time. Since it's a 1 incision technique, we can predictably have first intention wound healing, and we will have stability of that area and an uneventful healing most of the times. We use this kind of tissue as we talk in the aesthetic area, and in this area we use it in combination or with tunneling techniques or with a coronally advanced flap. In this video we have this one incision connective tissue graft used in conjunction with a coronally advanced flap. Here we see it being stabilized with the sutures, and the flap, the overlying flap, advanced and stabilized around the teeth by end covering multiple adjacent gingival recessions. With now, this work was done also with João Fonseca, which is a Portuguese prosthodontist, and we have used here some quality control, digital quality control of these tissues, and we, by overlapping a scan before and after the healing, we can know for sure what we have achieved. And here we have the before and after, the result. On the right side, the upper right side, we can see a complete root coverage of these areas with a coronally advanced flap. And on the left side, we have, which have had more advanced recessions, you can also see a complete root coverage of and very good healing of the connective tissue graft, which of course has an impact in this patient's smile and her overall happiness and comfort with her aesthetic results and her smile, and she'll now advance to an aesthetic treatment. A very old graft that we can also take from the patient's palate is the free gingival graft. The free gingival graft, by using this technique, we harvest both the epithelium and connective subepithelial connective tissue, directly subepithelial connective tissue, which we call lamina propria, that is whitish tissue that we can use to suture and manage in a lot of different ways. How do we harvest the free gingival graft from the palate? Usually use a more distal and posterior area of the palate, distal to the palate rogue, and we use these incisions perpendicular to the patient's palate and not beveled, and then we dissect the palate by not becoming too thick or too thin. Usually 1 millimeter, 1.5 millimeter graft is enough to every indication. We leave the apical incision to the end because now it becomes, the bleeding becomes a lot more profuse. So we leave this last incision towards the end. And then we have a management phase of our graft, where we cut the non-supported epithelium, and we cut the excess fatty tissue, and we protect the palate or with an acrylic stent, or if the patient has natural teeth and exposed enamel, it's very interesting to use a fixed protection of the palate that will promote a very good and uneventful healing, even if a free gingival graft is used. Because with the free gingival graft, we leave an open wound that has to heal for a secondary intention, and we have to protect it very carefully to be able to use it. Here is a patient that I observed in 2013 and 2019, and we can see the thin phenotype that she had before and the progression of the recessions. Of course, the central left lower incisor, it's our concern here. And since we don't have a good gingiva apical to recession, we use here a free gingival graft. We decontaminate the denuded roots by removing all the biofilm of the exposed roots. Here we use the erythritol powder, and then we use the free-gingival graft technique that consists of creating some recipient bed with exposed connective tissue. We deepitalize this recipient bed, and it can expose connective tissue that will vascularize our graft. We also deepen the vestibule, and we clean the roots by scaling and root planning. We have some management to do in our free-gingival graft, and we suture to the recipient bed and the surrounding periodontal tissue with our sutures and around our teeth, with both positioning and periostal anchorage suture, so we can promote a stable graft that will give us a very good healing, hopefully. This is the 1 year result, and this is not an aesthetic procedure. We can expect the free-gingival graft to heal with a whitish color that is typical of our palate, but we promote a very nice new periodontal attachment that enables this patient to clean. That's the most important thing, to keep oral health and periodontal health in this area, and she can now clean. And we question, since we also did the same procedure on the lingual side, if really having a lot of bone is very important for periodontal health. It's not, because in the natural dentition, lower incisors usually don't have a lot of bone already in the first place. So what is key in this area is to have a very good soft tissue attachment to the dental root, both in thickness and keratinized tissue, ideally with gingiva. We published with Myron Evans and David Kim from Harvard our results and the case series of this treatment on the lingual side, and I'm showing you a case of his with 30 years follow-up then, and we can see on the right side a 30 years free-gingival graft healed around teeth. So this is a very predictable treatment, also on short term, also on long term. Then we can use it comfortably also to improve keratinized mucosa around dental implants. That is also very important, and more studies come forward with that information as well. And hopefully we can solve these kind of problems, but ideally we should prevent these problems, because in most areas, especially in the posterior mandibular area, lower area, we have very small amounts of remaining keratinized tissue that we have to distribute around our dental implants. Usually we'll find very commonly situations where we have 2 or 3 millimeters, and the challenge is to augment this area without making the patients come through a lot of surgeries. So what we try to do now is place the implants with the simultaneous free-gingival graft in the posterior mandible, where we create a recipient bed. We deepitalize this area, deepen the vestibule, and stabilize free-gingival graft. And we took this opportunity as well to improve the periodontal attachment and the gingiva in the neighboring tooth. So we started with a very small amount of keratinized gingiva, and we end up with 2, 3, or 4 at least millimeters of keratinized mucosa around our implant. And we also managed to improve the profile and the height of soft tissue, which is very important to maintain bone stability around our dental implants. And we have here the result after 1 year. So in only 1 surgery, by doing this technique, we can improve the soft tissues without making the patient go through a lot of procedures. We also use the deepitalized free gingival graft, where will use the lamina propria part of this tissue. And usually this technique enables you to harvest large quantities, not as large as if we have substitute, but large quantities at the expense, of course, of patient comfort and post-op morbidity. But if we really want to use an autologous graft, we can use it. And there are some indications, and I believe this was an indication, since we have some very small amounts of gingiva apical to the recession, and we wanted to change also the periodontal phenotype. And this was, for me, an indication to use an autologous graft. This patient only wanted to do one procedure. Sometimes patients ask us this. So we harvest the tissue from both sides of the palate and stabilize it site-specifically in the most deficient areas of gingiva apical to the recession. We cover you use the coronally advanced flap technique, and we suture it around our teeth, and we end up with a very nice 6 months result in all of the areas. Of course, some of these areas were class 3 recessions, so we will not end up with complete root coverage, but we have a very nice improvement with only one surgery in this lower teeth area. Another technique that we can use is channeling, which is a very special technique, and we can use it without superficial incisions and having the risk of creating scars and superficial scars. And we use it in areas with a high demand of aesthetics and patients with a high demand of aesthetics, because usually is a technique that has a very nice and uneventful healing. Here we did just that, and we used the one incision connective tissue graft in these 4 teeth, where we stabilized the connective tissue graft, and we used the modified coronally advanced tunnel to stabilize it around flowable composite in the interproximal spaces. And this technique will give us a very beautiful healing and unconspicuous integration of soft tissue. And it's a very used technique, because patients nowadays want more and more predictability and aesthetics, and will not be keen to accept less than optimal results with our procedures. And this is a 1-year result, and the patient is very happy. I'm ending my time, so but I will leave you with some final reflection, final thinkings. We saw here, we watched here a very extensive surgery, but usually the most difficult surgeries are the smallest ones. This patient had a very high demand, and she didn't want this darkened root and exposed root. And I will tell you, even if it's just one tooth that is being treated, this is a very difficult technique. Small recessions in aesthetic areas, in high demanding patients, are usually more difficult procedures than most extensive and complicated surgeries. Here we have a nice 1-year result, also using the modified coronally advanced tunnel. Some very new perspectives we have with tuberosity tissues, and by solving complications like this, because tuberosity has the capacity to grow on a height dimension, on a vertical dimension, and we can use it as a platform and use it as a vertical thickening of soft tissues, and hopefully help to treat cases like this. And we are seeing this more and more, and this is of course difficult cases and the challenge, and we'll use soft tissue management more and more to solve these kind of problems. Of course, we always have the pink porcelain option to treat some cases that and patients that don't want to go with the soft tissues autologous autologous graft, and we also have this option, but it's not for every case, and it has to be carefully selected. During this half an hour, we talked about soft tissue, but more important than that is also the provisional restoration that shapes our soft tissue reconstruction and also the underlying bone that supports these soft tissues. We also, it's very important to use microsurgery principles for illustration purposes. Here, the very same technique and the same kind of graft sutured with 5, 6, and 7-0 sutures, and of course with very different hurts, surgical trauma to this tissue, and it's very different that if you use microsurgery instruments and blades and sutures to do this kind of procedures other than other instruments. Also, one last idea that plastic surgery is not only cosmetic surgery. We often do these techniques with an aesthetic indication, but this plastic periodontal surgery is also used to improve health and function of both our teeth and dental implants. So this is not an aesthetic surgery only, but it's very important to have the skills to manage soft tissues if we're placing dental implants, or if we're trying to solve gingival recessions. And with this, I thank you for your attention and your participation in this day. And it's very special to be here with you, Sofia Aroca and Professor Tondela. And of course, you'll always be invited to come here to Lisbon, my hometown, and I hope to see you soon.
Thank you, Dr. Gonçalves. This was very, very nice presentation. It would be better if we had a lot of time, because you just point out the different aspects. It was a very comprehensive presentation, and of course, maybe one day we'll have an afternoon to discuss all these subjects, and I think we would be very pleased to have you doing this. But even so, I have one or two questions to put to you, to present to you after your presentation. I would like you to address this point. Which are the conditions, the local conditions, that you consider mandatory to have before going into surgical regenerative procedures, namely periodontal or soft tissue or bone augmentation? Which are the mandatory conditions that you have to get before you going into surgery?
Yes, this is a very important question. Of course, my presentation only, given the limited time, we only addressed some issues, but the issue you bring up is very important because we only go forward to this kind of procedures if some local and overall health of the patient are met. For example, we have to have systemic health and underlying conditions under control, but that is true for periodontal surgery, but it's also true for all surgery or oral cavity surgery. And locally, we always have to have periodontal health and very uninflamed and healthy tissues for us to be able to manage. If we try to do this kind of procedures, and I think I showed you hopefully only cases with healthy tissues, but if we try to do this without periodontal health in the area, we will not be able to open a flap in partial thickness. We will not be able to suture. The healing will not be uneventful, and it will be much more complicated. So usually this achieving some health in the area that is to be treated is paramount for success. So
Okay.
usually the patients undergo a phase of regular cleanings before even being eligible to do this kind of procedures.
Yeah. Thank you for your very clear answer. When you also show us the different kind of soft tissues grafts that you use and you can get from the palate or other sites in the mouth of the patient, what are the most frequent and important complications, and how do you deal with this at the donor site?
At the donor site?
Yeah.
Yeah. In my practice, the most common complication is bleeding, because of course we discharge the patient without bleeding, but sometimes during their everyday life they tend to not follow completely our post-op advice. So giving a very good and comprehensive post-op advice is very, very important. Sometimes we have some bleeding, we have some opening of the wound with pain, but I believe that these complications throughout time and our practice will be much less common with the development of our surgical technique and techniques of harvesting the tissue from the palate. So opening of the wound, and opening the wound means that the patient will bleed and have more pain that it could have, is perhaps the most common complication. But given the today's status and surgical techniques, this is not very common without the patient tells you that he did something wrong and not following post-op advice.
Yeah. Do you use glue, any kind of glue, cyanoacrylate glue, or do you use palatal splints to protect the wound?
Yeah,
you don't do that usually.
Usually, no. On the anterior palate, since we have first intention wound healing, I don't do anything, and usually the healing is uneventful. On the posterior palate, using a free gingival graft to use as a free gingival graft, or to deepitalize and use as a connective tissue graft of the lamina propria part of the tissue, I use an acrylic stent. If the patient has like a total fixed bridge, for example, and you cannot glue anything to the teeth, but if the patient has natural teeth, I use resin and the collagen sponge to stabilize the area, and I use it recently and with very different post-op results for the patient, and a low incidence of complications and bleeding.
Yeah,
so usually this is the post-op care of the donor area, but if I wouldn't be using the composite and the resin composite, perhaps I would use the cyanoacrylate glue, because I think it's very important to have something that protects the wound and don't leave it open after the surgery.
Okay, thank you. And just a last question. When you are treating implants or soft tissues around implants, of course, there are some difference on the type of tissues, comparing it with teeth. Is there also some different criteria or to proper select the technique and the material to use?
Yeah, that will be a very long conversation. So perhaps we will need that afternoon. to talk about that. But to not leave this without an answer that people that hear from us can have something from this. What I can tell you is that it's very common for in lower implants with a low amount of keratinized mucosa to use fringivore grafts. It's a very common technique to improve the keratinized mucosa. And it's also, especially on upper implants that usually don't have this low keratinized mucosa problem, but can have more frequently aesthetic concerns from the patient. We tend to use more and more tunneling technique instead of coronally advanced flap, because we know that papilla healing around dental implants is much more difficult than papilla healing around teeth. So we'll think 100 times before elevating a flap, including the papilla around the dental implant, and we'll use much more tunneling techniques.
Okay, it was very precise, your answer, and I think it leaves us with this afternoon promise to have place one of these days.
Of course.
So I think it was a wonderful time being here with you and Sofia Aroca, and also the presenters before. And thank you very much in my personal name and in behalf of myself and Botis and Klockner. And we'll meet again soon. Presently, hopefully.
Hopefully.
Yeah. Bye-bye.
Thank you. Thank you, Professor Tondela.